radioactive bead localization or radioactive seed localization. Iodine 125. Right, so that can be injected around the area or close to the area and then identified at the time of excision.
Doc, is that the role? Like,
no, that's not role.
Oh, okay.
Not role. So the role is using technetium, I believe.
Oh, okay. And you said the other one,
so the radioactive seed localization is actually beads that they're using with iodine 125 beads.
Oh, okay.
So these are injected around the area.
Okay, thank you.
We don't have that here though. No problem. All right. So those are ways that we biopsy non-palpable lesions. Very good. And the stereotactic, we didn't really go into it, but yes, that's just using mammogram to guide the biopsy, core needle biopsy. Okay, so that's the third step in the triple assessment. Now, next person, I want you to just step me through what you look for on these biopsy. What are the findings we look on for the histology? Well, not histology. You send a sample to the lab. You're going to tell me what you're sending it for, and how that can help you. That's the next person.
Okay, no problem. I think I can do this part. All right. So when we send the samples to the lab, which is a core needle biopsy, first you want to find out if the cells are malignant or not. If it are malignant, then the next step, that three things, it gives you if the cells are invasive or not, and also it can give you the immunohistochemistry of the cells.
So you want histology and you want IHC. Histology and IHC. Okay, 67 years, very good. We can also get that from the biopsy. What about cytology? Is that important? We look for cytology on this.
Isn't the cytology itself going to let us know if the cells are malignant, like the architecture of the cells, and then it can also tell us if they are ductal versus lobular cells?
Okay, so cytology can tell you if you have malignant cells, but it can't tell you if this is cancer. If it's invasive cancer. All it will tell you that the cells are atypical. Okay, you have abnormal nuclear to cytoplasmic ratio, increased mitosis and that kind of thing. You just look on the cells, literally just the cells. It doesn't tell you about the basement membrane. It don't tell you if it's invading. It don't tell you any of those things. Perineural invasion, all of those things. It don't tell you, give you architecture. So that's why we don't do fine needle aspiration cytology for breast lumps. Right? That will not tell us anything. It could be DCIS. Well, we know it could be atypical ductal hyperplasia. You see some atypical cells, it could be anything. It doesn't have to be breast cancer. It could be atypical ductal hyperplasia. It could be DCIS. Right? So you can't differentiate any of those things. You can't tell us if it's atypical ductal hyperplasia. You can't tell us if it's DCIS. You can't tell us if it is invasive ductal carcinoma. That's why cytology by itself is not adequate. And so histology. So cytology is one thing. Now go to the cytology lab. Histology go to the pathology lab. Two different labs, two different things. Histology give us architecture. Tell us the whole thing, right? The lumen straight through. All right. So from that now we can tell if it's invasive or if it's in situ, right? Or if it's just atypical ductal hyperplasia. All right. Um, so this patient, so the histology comes back showing invasive ductal carcinoma. Invasive ductal carcinoma. And you say IHC. Tell me about a little bit more about IHC. What's this IHC? What we're looking for in plain language?
Well, it tells you the receptor status in plain
Very
language.
good. Receptor status. What are the receptor status?
Well, the receptor status that you can get is if it's luminal A, luminal B, HER2 enriched, or if it's triple negative. And then on that, you can differentiate between the luminal A versus the luminal B as Jeremy
mentioned. So in plain language, they are estrogen receptor, progesterone receptor, and HER2 receptor, right? And we can have any combination of those in terms of positivity or negativity. So 3 receptors. That's what we look for with the IHC. And somebody mentioned KS67. All right, cool. Now, what do we do with this information? We have 10 minutes. 10 minutes left. What do we do with this information?
Well,
So
this
we have a patient with invasive ductal carcinoma, right? Confirmed based on the histology, and the IHC. 2 weeks later, we get back the reports showing ERPR positive, HER2 negative. Sorry, ERPR positive, HER2 positive, triple positive. Let's touch on each of them. So ER triple positive, um, invasive ductal carcinoma. That's what we're dealing with.
Well, in this case, given that all receptor status are positive and these cells are very aggressive, you'd want to consider giving this patient prior to surgery neoadjuvant therapy
So you
prior.
get catch. So you get catch in the exam, Delmar. We run Ghana at surgery.
No, I'm not saying prior. You don't want to give them neoadjuvant
But
downside
we just diagnose the patient. What's the
and
fourth step in the quadruple assessment?
stage them. Oh, right, you have to.
Yes, right. So if you don't learn anything else today, or if you don't remember anything else from today's session, you'll remember that after diagnosis is staging. In the exam, when you get cold feet and you start getting anxious and everything, you jump from exam to surgery. A patient have a 2 centimeter lump, I like to do breast conservative surgery. I don't remember nothing about biopsy, you don't remember anything about staging, nothing. That's why you go in exam. Right? So that's why we're going through like this. So that you don't get catch. You don't just go in the exam and say, oh, I think this patient have breast cancer. Right? 2 centimeter lump. Okay, 2 centimeter lump, that's small. All right. How do you manage this patient? I think this patient is a good candidate for breast conservative surgery. No, the examiner don't want to hear that. The examiner want to hear I would like to do a thorough history, go through risk factors, even if you don't reach the surgery part. They want to know that you go through the steps. You're not gonna research. You're not gonna reach so far. You just have what, 5 minutes, 2 minutes to discuss. You're not going to reach so far. But if you are efficient, you can reach far. Just hitting the buzzwords, right? Hitting the point. I'd like to do my triple assessment, starting with thorough history and exam, based on the Cicerone exam, I think this patient clinically has a T2N1 lesion. I'd like to proceed by doing, ultrasound and mammogram or sonomammogram, looking for confirming the size and associated lymph nodes. And if there's any, use Barrett score, just drop in the Barrett same time. If it's Barrett's 4, I'd like to proceed to doing the third step in the triple assessment, which is based on the fact that this is a palpable lesion, I'd like to do ultrasound guided core needle biopsy. From that, I can get histology and IHC, and based on if that comes back showing invasive disease, um, depending on the IHC, well, I'd like to proceed with staging, right? If it does come back showing invasive disease. No, staging, that's where you're coming there. Once I reach the staging, very quickly can get to staging. But it's important that you go through the steps, step by step by step, and you don't forget the different stages, right? Now I want somebody else to tell me the staging. Just touch on staging for me. Delmar, you can continue.
Okay, doc. So at this point now, in regards to staging, this is where we want to know if if it's the metastasis or not. So we want to do a CT, computerized tomography of the chest, abdomen, pelvis, plus a bone scan.
Very good.
Because it's important to note that breast spreads to LLBB, which is the liver, lung, brain, bone, and this can help to determine
Bone brain.
bone first. Yes, this can help to determine next in terms of the overall management of the patient.
Okay, so that's the end stage. Fine. Um, you don't need to oversell it. So CT, chest, abdomen, pelvis, bone scan, that will give you the distant mets. But you also use ultrasound to tell T and end stage, right? So you can say coupled with it, the ultrasound for the TN end stage, I would like to do a CT, chest, abdomen, pelvis, and bone scan to determine the distant metastasis, if the presence of distant metastasis. If this patient is M not, meaning has no evidence of distant mets, then I'd proceed by doing, who's next? Who's gonna wrap it up? Thank you, Delmar. Who's next? Come on, man.
You said the patient was N not, doc?
M not, meaning no mets.
Or M not.
Mm-hmm. So you want me to summarize again? So we have a T2, N1, M not, triple positive, breast, invasive ductal carcinoma. How would you proceed?
Yeah, I can attempt it.
Because, wait, I want to know if, what was that a while ago?
Oh, it was, I spoke earlier though, so if somebody else.
Yeah, I want somebody else. Somebody fresh. Nobody? All right, go ahead.
Oh, okay, so management would be multidisciplinary. So we need to have the surgeons on board and the radiologists and the hematologists as well for the chemo aspect.
Mm-hmm.
We'd have to consider the patient's desires as well in terms of if they are desirous of surgery. Based on the stage, so this would put the patient at a stage 3 since we have regional lymph node involvements, if I understand correctly.
That's true. That's not true.
Not true, sir?
No.
Oh, okay. So I think it depends on the mobility of the lymph node. So about
It's
stage
not
3.
important for you to say stage 1, 2, or 1, 2, 3, or 4. What's important to know is the T stage, N stage, and M stage. So I think this patient is stage 3 versus this patient is stage 2. That don't really help you in terms of the management. What helps you in the management is knowing if the patient is T1 or T2, N1 or N2, M1 or M not.
So in this case, then I would want to offer neoadjuvant. I could do both neoadjuvant chemo and hormonal therapy. For the neoadjuvant, especially in this patient who is triple positive. So I'd want to offer, and she's postmenopausal, so I'd want to offer your aromatase inhibitors. So like your anastrozole or letrozole. And then we could consider chemo, neoadjuvant chemo based on her Ki-6 or 7. So
Okay, so we'll get into the weeds of the neoadjuvant therapy. So you want to offer neoadjuvant therapy. What's the basis of for offering neoadjuvant?
So the goal is to try and downstage the tumor and to also figure out what the tumor will respond to after surgery.
Mm-hmm. Okay, so downstage the tumor. In a view to why you want to downstage it.
To
What's
reduce
the
the
what's the
risk
end goal?
of
What's the plan to do in terms of
to
after the
do
neoadjuvant?
complete resection, or we're going to do a modified
What
radical
are the options?
mastectomy.
Oh, you went to a modified radical mastectomy on this patient with a T2N1. Okay.
But
Why
based on the
modified
fact
radical mastectomy?
because there are lymph nodes, so I would want to address the lymph nodes. I
What is a
don't
modified
know.
radical mastectomy?
So you say modified radical, you're removing the breast tissue. You're also removing the fascia and up to level 2 lymph nodes.
Okay. You think this patient warrants all of that?
I could do sentinel lymph node before.
Sentinel lymph node before. No sentinel lymph node reaching this arc in this patient. In the discussion of this patient.
So the main reason I mentioned it is because the lymph nodes, I just wanted to do a procedure that could address the lymph nodes.
All right, so we'll talk about the indication for sentinel lymph node biopsy shortly. I'm going to give an additional 5 minutes. I'm going to just talk about this part quickly. All right, cool. So we're at the point of management, definitive management. This patient has, we know, T2N1M0, invasive ductal carcinoma. Invasive ductal carcinoma, triple positive. All right. So in the regular runnings, this patient would have been discussed at multidisciplinary meeting. Well, I mean, it's not absolutely necessary for everybody with breast cancer to be discussed at MDT in a practical sense, right? If the patient has like an indeterminate lesion or something, then he can discuss. But yeah, so but it won't harm if you mention multidisciplinary meeting. Um, but essentially, this patient would get neoadjuvant treatment. Why? They'll get neoadjuvant treatment. So they'll get neoadjuvant therapy in a view to, well, because they have because they have nodal disease. So everybody with nodal disease requires neoadjuvant chemo, right? So regardless of the T stage, once you have nodal disease, you need neoadjuvant chemo. If you have T3, you definitely need neoadjuvant chemo. Neoadjuvant treatment. So T3 or any nodal disease is an indication for neoadjuvant chemo. Now for smaller lesions like T1 and not, you know, only in very aggressive disease you would need neoadjuvant chemo. So triple negative, HER2 positive, right? Those are absolute indications. So absolute indications for neoadjuvant chemo include one, HER2 positivity, two, triple negative disease, three, locally advanced disease, so like N1 or T3, right? Those are, that's all you need to know. Those are the indications. If I'm asking for indication for neoadjuvant treatment, one, two, three, done. Now, why do we do neoadjuvant? We do neoadjuvant treatment to, to downstage the tumor, and also it does correspond with overall survival, decrease recurrence. Well, actually, decrease recurrence, local recurrence, right? And it also increase the likelihood of breast conservation surgery in more advanced disease. All right, so those are the reasons. We talk about the indications. We talk about the reasons, or the benefits rather for doing it. Now we can monitor the response. That's another
Hi.
benefit.
Hello.
Yes,
You said to decrease the likelihood of what?
local recurrence.
Oh, okay, thanks.
Mm-hmm. And you can monitor the response, in vivo response, right? Now, so that's neoadjuvant. So we've done neoadjuvant. Now we're talking about surgery. What are the options? Surgical options for patients with breast cancer. In general, we have the starting from the more conservative options, such as breast conservation surgery, or breast conservation therapy rather. Breast conservation therapy, you guys would have heard of that before. This is a combination of wide local excision plus radiotherapy. That's a package, it's a package, like a combo. Like you go KFC and you get like a meal deal, you get chicken and fries. You go together, like a combo. That's breast conservation therapy, right? Breast conservation therapy. That's surgery plus radiotherapy. There's not one or the other, or one without the other. You have to get the combo. You can't say, okay, I want sandwich alone and no fries. No, it don't work like that with breast conservation. Breast conservation means that if you get breast conservation surgery, you have to get radiotherapy with it. Have to. Or that option is not available otherwise. All right. So that's one option. Second option is not modified radical mastectomy. We don't use that term That's kind of loose. But we use total mastectomy. So mastectomy by itself, mastectomy, and then we have other forms of mastectomy, such as nipple sparing or skin sparing mastectomy. So those are forms of mastectomy, right? Um, so when we talk about breast surgery, we usually talk about when we talk about breast cancer, we usually talk about the breast surgery for the breast, and then surgery for the axilla separately, right? So if you have a page on your book, and on at the top of that page it says surgery for breast cancer. You can draw a line down the center of that page and you say sur- surgery on the breast, and on the next side of the line you're gonna write surgery for the axilla. Right? Now, in relation to the side with the surgery for the breast, are all of those things that we just talked about. The options: breast conservation therapy and mastectomy, whatever form of mastectomy, right? So those are the surgery for the breast. Now, on the other side, now when you're talking about surgery for the axilla, we're going to be under that side. We have sentinel lymph node biopsy as one. Next, you have axillary lymph node dissection as the other option. And of course, everybody can get everything, right? You have to know which surgery is fit for which patient. The easiest indication to remember is for sentinel lymph node biopsy. When we're talking about axilla, sentinel lymph node biopsy. Who is fit for sentinel lymph node biopsy? Patients who you cannot feel the lump, right? Clinically negative lymph node. So they can't feel any lymph node, clinically negative and radiological. So clinically negative or clinically node not really means on examination and on radiology. So clinically, in this setting, as it relates to the lymph node status, incorporate the exam, physical exam, and radiological. So you don't have to be redundant and say clinically and radiologically negative lymph node. Clinically negative lymph node is it's understood that you mean physical exam and radiologically. So that's the indication for sentinel lymph node biopsy. Now, anybody outside of that require axillary lymph node dissection, like our patient here who has N1 disease. You can feel it from the exam station there. In the exam station, you feel a lymph node there. You don't know this patient is not a candidate for sentinel lymph node biopsy, right? So if you see methylene blue on the shelf and them say, you're going to use this for this patient with a lymph node under the arm, you're going to say, no, this patient does not require the methylene blue, right? The patient is not a candidate for sentinel lymph node biopsy. You try to trick me, right? This patient requires axillary lymph node dissection. All right, cool. So in terms of sentinel lymph node biopsy, you have two, there's a whole long discussion you can have about that. The methylene blue and technetium 99 dual localization method. Those are used to localize the sentinel lymph node. And usually we take about 2 to 3 lymph nodes. I see somebody posted Z11 trial there. I mean, yes, if you get to it, yes. But Z11 essentially it says that if in a patient who's offered breast conservation surgery or breast conservation therapy, if the sentinel lymph node comes back positive, then, well, 1 to 2 lymph node positive, the patient can be observed. You don't need to go back and do a completion axillary lymph node dissection, right? Essentially, it made the work easier for us. That's why we love Z11 so much. We don't have to stand up in theater the whole day and wait on the sentinel results to come back, right? So, but this only applies to patients with breast conservation who's doing breast conservation surgery. All right. Now, just wrapping up. So I mentioned the indications for sentinel lymph node biopsy and axillary lymph node dissection. So that side of the paper is good. You don't know about the axilla. indication for the axilla, surgery for the axilla, surgery for the breast itself, no. The breast, we mentioned breast conservation surgery, and one of the more popular questions is indications for breast conservation surgery. But nobody don't want to cut off them breasts, right? Everybody wants to keep their breasts. When I see a patient in the office, patient's gonna ask, doc, their biggest concern is that they're gonna lose their breast, right? No, the patients that you're gonna reassure that okay, you don't need to, you know you can't we don't need to cut off your breast. Yeah, breast cancer, but you can relax. We can just remove that area if and only if you have a T2. So no more than a T2. T3, no, it's a no. T2, T1 to 2 rather. N, well, N doesn't come in. We're just talking about T stage. T1 to 2, if there's no multicentricity, meaning you don't have lesions in different quadrants, right? They're only focused in one quadrant. So T1 to 2 lesions, and multifocal, meaning only in one quadrant. Multicentric is a contraindication, right? And if I mean a relative contraindication is the large tumor to breast ratio, and then no indications for radiotherapy. So if the patient has contraindication to radiotherapy, meaning they can't get radiotherapy for whatever reason, then they're not a, remember we say it's a combo. So if you can't get that part of the combo, then you can't get no part of the combo, right? You can't get breast conservation therapy, right? So contraindications to radiotherapy equals contraindications to breast conservation therapy. And these contraindications, as I just saw, active collagen vascular disease, pregnancy, um, if radiotherapy is just not available, if you have prior radiotherapy to the area, all of those things, right? So those are contraindications to breast conservation surgery. And we mentioned the tumor aspects of it. So T2, T1 to 2, and not. Um, no, sorry, the N doesn't come in. T1 to 2. Okay, so outside of that, the default is mastectomy, right? And we've spoken about different forms of mastectomy. All right. So I think we've covered the main areas. And the only other thing, I mean, aspect of the topic that would be relevant is screening itself, going through mammograms, mammogram findings, when we screen, know about, we don't want to go through it. I just need to remind you guys that you need to review it. Um, okay, the surveillance after surgery. So of course, the patient, you can send out the sample to the pathologist, and you will see, the pathological staging, and if there's any margin involvement, etc. If the patient had completed neoadjuvant treatment, then you don't need adjuvant treatment, and essentially physical exam every 3 months. Um, yeah, and CT at the 1 year interval, 3 year and 5 years. All right, and if the patient is hormone positive, then they continue with tamoxifen. Well, depending on pre or post menopause. Right, if they're post, then is anastrozole or aromatase inhibitor. Yeah, right. So going back now, I was reminding you guys to just go back through screening, mammogram. The views from mammogram. You know, um, how we risk stratify, which we have touched on. Know about prophylaxis. Breast reconstruction, yes, they may sometimes bring the prosthetic. Yeah, so know a little bit about breast reconstruction, the types, the flaps and them things. Tram. Yeah, so we don't have time to go through all of that, but yes, do touch on those. Michaela, you have a question?
Doc, you were mentioning breast reconstruction and also you mentioned Z11 earlier. Could you touch on that and tell me a bit more about it, please?
Yeah, so the topics I'm touching on right now are the ones that I just want you guys to go and read through because we don't have time to go through all of them. Right, so breast reconstruction, as I mentioned, you just know the types of reconstruction, right? The types using synthetic or autologous tissue. So tram flap, I'm sure you'd have heard about reconstruction and you'd have heard about the types of reconstruction. So you can just review that, right? And yeah, and in terms of the Z11, we had spoken about, the results of that and how it impacted how we manage the axilla. So essentially saying that we don't need to do completion axillary lymph node dissection if we have a positive sentinel lymph node biopsy. 1 to 2 positive sentinel lymph node in a patient who is undergoing breast conservation therapy. Um,
I'm
and
sorry, Doc.
that's partly because the patient is gonna get radiotherapy, and we assume that radiotherapy is gonna sort out the axilla
Doc, could
if you have
you
a positive disease.
I'm sorry, could you
Mhm.
repeat the 1 to 2 positive lymph nodes? What were you referring to?
All right, Z11 trial. I'm going to say it one more time. So the Z11 trial speaks to the management of the axilla after sentinel lymph node biopsy. As you know, for sentinel lymph node biopsy, we're going to be taking about 3 nodes or so, 1 to 3 nodes, right? So we, having taken those nodes, of course, we want to know if them positive or then negative, right? If 1 or 2 of them positive, what are we going to do with them? Are we going to, if 1 or 2 of them positive, the question is, should I go back and take out everything or not? Or should I just leave it alone? That was a question that was unanswered before 2011. What question is that? The question is, should I go back and take out these all, should I do a full axillary lymph node dissection? Because the sampling, the sentinel lymph node sample come back positive. 1 or 2 of them come back positive. So I'm gonna call the patient and say, hey, Mary Jane, 1 and 2 of your sample positive. I have to go carry back a theater. I'm have to go check out the rest of your lymph node. And Mary Jane, I'm gonna say, Lord God, one next surgery, right? And then you're going to carry back Mary Jane and you're going to do level 2 axillary lymph node dissection. All of that. Stress out poor Mary Jane. Right? That used to happen before 2011. Since 2011, Mary Jane, you call Mary Jane and Mary Jane says, and you tell Mary Jane 1 or 2 of your sentinel lymph node them positive. But guess what? We don't need to carry back a theater. You just go and go do your radiotherapy like we did plan before. Because that was already in the plan. You were already scheduled for radiotherapy because we did breast conservation surgery. Breast conservation surgery and sentinel lymph node biopsy. If the sentinel lymph node biopsy comes back positive, 1 to 2 of them, you don't need to worry your head, Mary Jane. Mary Jane, you just go and do your radiotherapy. That's what Z11 says. Is that clear?
Yes, Doc. Thank
Perfect.
you.
All right.
Doc, I had a question.
Mm-hmm.
In terms of when you're assessing the patient for metastasis, which investigations are standard versus which ones are done if the patient is symptomatic?
Okay. So standard, very good question. Um, so standard investigations at this time is CT, chest, abdomen, pelvis, and bone scan. And then if the patient has, any features of CNS Mets or Mets to the brain, that's when you do MRI of the brain. So that's not standard. MRI of the brain is not standard. Only if they're symptomatic.
Okay, so where would MRI is the same as the bone scan or that's slightly different?
No man, bone scan totally different.
Okay, so when you were talking about MRI earlier, what I didn't really understand the context.
We're talking about MRI of the breast.
Oh, okay, all right, never mind.
MRI of the breast. So MRI of the breast, that would be like in the same line with ultrasound and mammogram, in terms of imaging of the breast. different
Okay,
from
thank you.
staging. No problem.
Um, could you touch on like oncotype testing, genomic testing? When is that? When would you think of that? Like, is that something that we should know, or would you just want to highlight some stuff for us?
Well, if you're going for distinction and that kind of thing, sure, can mention oncotype. So it's in you. In general, you should just know the indication. It's not too much to ask you the indication for an oncotype or genomic testing. For genomic testing, pretty much you're looking at genetic mutation at the level of the tumor itself. We're not talking about the blood or the patient's hereditary or DNA, the patient's DNA. We're talking about the tumor itself. So that's what we're testing. So for those who don't know about genomic testing and oncotype, it's first time you're hearing about it. We're talking about testing the tumor itself for genetic mutations. Now, these by and large, the most common one is oncotype DX. When would we subject the patient to this expensive test, like 4,000 US dollars? When are we going to send patients for this test? So we send only a few patients for this. Well, would be indicated. Only a few patients. In only a few patients, this test would be indicated. Patients with ERPR positive, HER2 negative, meaning hormone type, right? The most docile type of breast cancer, least aggressive, right? So ARPR positive, HER2 negative, T1 to T2, right? So these patients, you really want to know if they can avoid chemotherapy, meaning you have hormone type breast cancer, right? You're 40, you have hormone type breast cancer. Do you really need chemotherapy? When we can, just give you some tamoxifen and you're good. That's really what this test is about. The Oncotype DX. So 40-year-old say, Lord, me no want a chemotherapy, me no want my hair drop off. Doc, is there any way we can avoid getting the chemotherapy? You're gonna say yes, but you have to go pay 4,000 US dollars to do this test. All right. Patient say yes. I don't want my hair cut off. I have ERPR positive tumor. Check if I can avoid chemotherapy. And we say, all right, we send the sample to get tested. The same sample that we did the core needle from. So that's the tumor itself. We send that. Well, in fact, it really should be done on the whole tumor. But we send it to be done, to be tested. And based on that, it will give us a score that tells us, the risk of recurrence if you don't get chemotherapy. And if that score is low, then the patient can avoid chemotherapy and we can just limit the patient to hormone treatment. So in essence, oncotype DX is indicated in luminal disease, ARPR positive, HER2 negative disease, early disease, in a view to avoid chemotherapy. If the recurrence score, that's the term, the recurrence score is low. That's clear?
Yes, it's very clear. And the
No.
luminal A patients would more benefit from it than the luminal B.
Well, luminal, the indication is ERPR positive, HER2 negative. So
Oh,
that
okay.
incorporates both luminal A and B. It's just that luminal B, has a higher Ki-67, and so
Mm.
it's a little bit more aggressive, but it does not. There's no correlation between luminal A or B. To say you don't use that to determine who gets to do the test, or you don't use that to determine if the patient can get chemotherapy or can get hormonal treatment alone,
Oh,
right? So once you fall in that category, ARPR positive, HER2 negative, then you you may avoid chemotherapy if the oncotype DX come back with a low recurrence score,
okay, great.
regardless of luminal ARB.
Great. Thanks so much.
No problem. All right. So I think we touched on the main topics as it pertains to breast. If you think about any other, then you can just we can start the next session with it, and we'll move on.
Doc, could I ask what would the next sessions be? The surgery sessions. What it
I'll let you know.
okay.
You guys can decide, and then at some point before the next session, you want thyroid, or we'll do thyroid next.
Thyroid, we could
Thyroid, sure.
protect AAA as well.
Thyroid. Mm-hmm.
Okay, thanks.
Sure.